friends. Sorry for being late. And we are starting today with GI bleeding in geriatric age group. Again, we are going to discuss only the clinical scenario as relevant to geriatric age group. So in age beyond 65, the overall incidence is decreasing. It is primarily because decrease in upper GI bleed. Elderly people on anticoagulants are at a higher risk of bleeding. The mortality and morbidity of GI bleed is higher in elderly population. The incidence is 60 per 100,000 for upper GI and 35 per 100,000 for lower GI. The mortality overall is 3%, and the upper GI has more mortality than the lower GI, primarily because the causes of upper GI, when they bleed for causes of liver, besides the bleed, there is a bad liver also. So the increased age increases comorbid conditions. Polypharmacy increases the risk of GI bleeding. Now, when I say polypharmacy, that means the patient is taking a lot of drugs, and the vulnerability of GI to the mucosal breach and the bleeding from GI mucosa increases, the coagulopathy increases. There are a lot of people in this age group who are on anticoagulants. The reasons are coronary artery disease, atrial fibrillation, cerebrovascular disease, and instant thrombosis prevention. So hence there's a large population which is getting antiplatelet or anticoagulants or both, which the combination of these two increases the risk of bleed several times. On an average, people beyond 80 years of age have got 13 per 100 patient years incidence of GI bleed in their first year. Now, with introduction of novel oral anticoagulants like dabigatran, the problems are unique because we cannot measure their effect easily. At the same time, we don't have an antidote precisely meant for them. They are good for the patients, but when the complication happen, when patients start bleeding on this, the situation becomes difficult. Now, these novel oral anticoagulants also have 25% more risk of bleeding compared to warfarin, and the risk from dabigatran over 75 years of age is 3%. When we consider between 65 to 84 years of age and beyond 85 years of age, the bleed goes up to 5%. Now, this is a brief outline of elderly scenario where we are going to treat GI bleed. Mainly, patients have coagulopathy as either a predisposing factor, precipitating factor, or a mortality morbidity fulcruming factor which modifies the outcome. Now, the common causes of upper GI bleed. So let me, for the youngsters, the upper GI bleed, you have only one cutoff line. Anything proximal to ligament of Treitz is upper GI bleed. Anything below ligaments of Treitz till anal canal is lower GI bleed. Now, two common causes are ulcer and gastropathy. The bleeding proximal to the ligaments of Treat or upper GI bleed can be frank, can be occult, manifest only by heme guaic acid test, can present with generalized features of anemia, weakness, asthenia, and microcytic hypochromic anemia. And it increases mortality with higher age group. The various other factors for the purposes of naming them are the varices, tear like Boerhaave, Mallory-Weiss syndrome, and angiodysplasias, hemobilia from liver, and in vascular prosthesis, aortoenteric fistulae. More popular than that, there are a lot of critical illnesses like people on ventilator in ICU, traumatic brain injury, burns can also predispose to upper GI bleed. The drugs, as we have discussed already, the antiplatelet drugs, number one, anticoagulants and non-steroidal anti-inflammatories contribute to upper GI bleed. When it comes to lower GI bleed, remember the most common, this is a good question for postgraduates to remember, that most common cause of bleeding per rectum is also upper GI bleed. In other words, all patients with lower GI bleed, we need to rule out upper GI bleed as a cause. When it is a lower GI bleed, 80% of it will stop spontaneously. You do nothing, just supportive measures, and the bleeding stops. And 25% will recur. The mortality increases with age. There are two slabs, 65 to 80 and 80 and above. Now, there are two common causes, I would say three causes for lower GI bleed. Number one, severe lower GI bleed is usually secondary to diverticulosis. Self-limiting large amount of bleed which gets settled itself. Low-grade chronically bleeding patients are usually secondary to clonic neoplasms. And the third cause, which constitutes around 30% of population in elderly group, is angiodysplasias of the colon. Besides that, inflammatory bowel disease, infective disease, amoebic ulcers, these are few more things. And all the causes of anorectum giving rise to lower GI bleed, namely hemorrhoids, fissure, and solitary rectal ulcer. You know, for young surgeons, for the exam going candidates, you should know at least 10 lines on solitary rectal ulcer, diagnosis, management, and the presentations. The third point is obscure GI bleed. Obscure GI bleed means when the cause is neither found on upper GI endoscopy nor on lower GI endoscopy. And common causes are angiectasis and tumors missed on endoscopy. Now, diagnosis of the GI bleed in elderly population is based on the first test is upper GI, if normal, lower GI. Scopy, angiographic, which can be diagnostic and therapeutic both. Nuclear investigations, CT enterography, and capsule endoscopy. We'll discuss one by one. When it comes to endoscopy, it has limitations only in situations of poor preparation, and the complications and perforations are more common beyond 80 years of age, as elderly do not tolerate large volumes of preparation, can have adverse effects like dehydration, acute kidney injury. So the recommendations are against sodium phosphate and magnesium based preparations for elderly people. The use of split dose balanced spec solution is recommended. The elderly people tolerate upper GI endoscopy using a thinner scope better than younger counterparts, and acceptable even without sedation. And if somebody needs sedation, welcome Dr. Shakti. If somebody needs sedation, it has to be a monitored anesthesia. He cannot be given sedation and just forgotten. I must share with you, in my little life, I have known two people, elderly people, who died in big hospitals in Delhi. One died, a lady died during ERCP stent removal, and the second man died during esophageal biopsy. Probably the patients were not monitored by a skilled anesthetist, and the sedation was given, and the patient was irritable in a dark room, and the endoscopist said give 1 cc more and 1 cc more, and that is how eventually a dead body was wheeled out. And that's sad, but being aware through this media, I want to make aware that people beyond 65, they carry a very high risk of desaturating during endoscopy. So there should be a skilled anesthesiologist on the head end if we want to give sedation to such people, and it has to be incremental, stepwise. One large dose is not adequate until we are going to intubate and protect the airway, which is not possible. Now, angiography is the test when endoscopy cannot find out. So most likely the causes are in the small bowel, which are not picked up by endoscopy. So the angiographic bleed can be picked up when even it is less than 0.5 ml per minute. The side effects are the puncture site hematoma, bleeding, and formation of pseudoaneurysm. There is a substitute to that, which is nuclear scintigraphy. Technetium-99 labeled red cells, which last longer than sulfur colloid, are able to pick up 0.1 ml per minute bleeding. The test is non-invasive. That is an advantage, and there are no punctures and hence no puncture site complications. The other investigation is contrast enhanced multi-detector CT. This can also pick up bleeding less than 0.1 ml per minute, and in the pictures are taken in the arterial phase, and then in the residual phase to document how much angiographic contrast flush is available at the site of the bleeding. But this has two additional risks. Number one, the amount of contrast used in such studies is much more, which predisposes to contrast-induced nephropathy, as we discussed yesterday. And it also has increased risk of radiation. CT angiography is a test in which small amounts of neutral contrast are given, say 20 ml every 10-15 minutes, so that the contrast distends the mucosa and the distant small ball can be well visualized. A word about capsule endoscopy. This is also a usual Viva question, though it is several decades old technology, but for general surgery it still comes under the heading of recent advances in surgery. And first important thing is the candidate should know some basic steps, because it is a favorite question. The point is, it is a capsule taken which has a camera mounted within. The capsule travels the gut motility all through the intestine, and there are 8 sensors pasted on the abdominal wall which take the pictures, and these pictures are relayed through the sensors into the receiver, which converts into the pictures. And number 1, this is non-invasive. Number 2, it only gives a picture. It cannot give a clear-cut diagnosis because there is no histology involved in this. And the capsule camera system is passed out after 8 to 12 hours. The person reports fasting, and test lasts around after 4 hours. The person can take oral liquids and maybe semi-solids. The test recording lasts for 8 hours. Now, this has an important relevance in cases of Crohn's ileitis. It documents Crohn better than CT angiography or CT angiography, and hence for some limited condition it has a role. Otherwise, the accuracy to yield the diagnosis is from 30 to 69%. Picks up angiectasis better than others. Now coming to the management principles of GI bleed. The patient needs to be monitored, invasive and non-invasive both ways. 2 large cannulae to be started, blood to be typed and cross-matched. Now these people have a high risk of aspiration. Hence, all of them should have a nasogastric tube which helps 2-3 ways. It empties the stomach. Even in a lower GI bleed, lavage through the NG tube makes sure there is no upper GI bleed. The stomach is collapsed and the chances of aspiration are low. The patients are nursed with head and up. We need to take the detailed drug history in the early management regarding the details of antiplatelet drugs and anticoagulants and NSAIDs. The use of platelet when the patients are on antiplatelets, the platelet count will be all right. Now this can be a good Viva question that suddenly the examiner to shift your attention. You have come prepared for a inguinal hernia surgery because the message outside on day 1 is that there is a ventral hernia, there is an inguinal hernia. When you reach there, suddenly the examiner says, beta, this patient is on aspirin and clopidogrel and the hernia is obstructed. What you are going to do? Since a large elderly population is on these 2 drugs and they land up in emergency, so all of you should know the modalities to manage this. The use of platelet concentrates, FFPs and prothrombin complex concentrates and tranexamic acid can help such patients. Endoscopy is the primary line of management. Colonoscopy perforations are not rare in this age group. When there is a failed endoscopy, then consider angiography. On arrival, all these patients should have a Foley's catheter as the best index of hourly urine output. High dose, when there is even a suspicion of peptic ulceration as a cause of bleeding, high dose of proton pump inhibitor infusion is started, and the aspiration in first 96 hours can lead to pneumonias and kill the patient earlier from aspiration than from bleeding. Those patients who are having dementia, Alzheimer, obtunded, or really having a high fertility index, as we discussed 2 days ago, they should have their upper respiratory tract protected by intubation. Oxygen as a supplement to all GI bleeds should be given to prevent hypoxia, to decrease incidences of desaturation and arrhythmias. Early intubation is always life-saving when the risk of aspiration is high. Resuscitation modalities over a large trial, around 3,500 in both arms, patients treated with crystalloids versus colloids, eventually there is no difference in the outcome. Yes, a trend which is accepted, if somebody is having a large volume of bleed through GI tract, a very early transfusion modality of Paxil FFP platelet concentrate 1:1:1 ratio should be started early when you have a large loss before coming to the hospital and there is a continued loss during the stay in the hospital. Now, when the patient is on medications, the antiplatelet effect cannot be measured by routine investigations. So, since the count is normal, it is a functional abnormality. So, how to measure that? There are two tests which I will recommend all youngsters to read in detail, because this can be short note. This can be asked by the examiner, what are the recent tests? The recent tests are known as thromboelastography, TEG, or thromboelastometry. These are the tests to measure the clot formation, stability of the clot, and the viscoelastic properties of the clot. So these tests give more details, and a rapid test, a dynamic test can be done at the earliest, and the further transfusional components are decided on the basis of these tests. Now, FFP is a common modality to reverse all factor 7A activated and prothrombin complex concentrates and recombinant factor 7A help in treating such patients who continue to bleed. Now, there is a comparative study saying PCC corrected INR better than with FFP and vitamin K together. Also, PCC and vitamin K given within 8 hours of arrival of GI bleed decrease the mortality 2 times. So is the importance. So far, there is no antidote for novel oral anticoagulants like dabigatran. Now, because, and also the direct thrombin inhibitor. I tried to search quite a bit last night, and the two answers I got in a couple of papers was, since it is absorbed sorry, I'm not yet recovered from my respiratory catarrh. Two types of ideas which are on which the scientists are working. Number one, it is known that these oral anticoagulants are absorbed within 2 hours. So if they are taken in less than 2 hours, then giving large amount of charcoal to such people can diminish their absorption. Second, there are reports attempting to remove the drug via dialysis. So these are two things, but practically so far no antidotes are available. Now on endoscopy, when we have bleeding, the bleeding can be clipped, banded, or argon beam coagulation, norepi injection, which recurs. The endoscopy should be done on urgent basis, not emergent basis. What I'm trying to say, when a patient is bleeding, evaluate the patient, stabilize the patient. And now there is a large data to show that there are no differences in outcome between endoscopy done within 6 hours or within 24 hours. So take time to stabilize the patient. I have known of also at least half a dozen patients who from casualty. Now you see, in our private hospital the culture is, now the patient has come at 8 o'clock and the consultant has come for rounds at 8:35, 8:40. Now resident says there's a upper GI bleeder in the casualty. He says, what are the reports? He says, the reports are not ready as yet. He says, what is the blood pressure? The blood pressure was 70 to come and now it is around 90. Now, nowhere the pulse was discussed, nowhere the pressures were discussed, and it led into, welcome Dr. Kakkar. So hurriedly the patient is wheeled to endoscopy because the consultant has to go back. He says, anyway, we have to do endoscopy. We can't make out anything without endoscopy. Let's do it now. The endoscopy, the patient howls, a bit sedation, a hypotensive patient who was borderline compromised, he gets decompensated, and in endoscopic suite, the patient dies. I have known this at least half a dozen times where the decisions were taken for the convenience of the person, not convenience of the patient. So friends, youngsters, follow the rule. In the current scenario, people of my age, including myself, all our mistakes were buried in the graveyard without any litigation, whereas you guys will not be spared. So do not do anything which does not follow the textbook. So resuscitate the patient, evaluate the patient, then only take the patient to endoscopic suite. The colonoscopy, suppose on colonoscopy, you cannot control the bleeding. Still clip it, couple of clips around that area. Why? Because when you are going to do a angiography and you want to selectively embolize that vessel, then the clips will guide you on fluoro where the bleeding was. Similarly, if you find a small tumor which you cannot control the bleeding endoscopically, inject ink or tattoo it from inside out by injecting through the colonoscope, so that while you do a lap resection on such patients, you know where the lesion is, because when you're doing from lap, you can't see the lumen. The complications of cardiovascular and respiratory nature, see the difference. That's what the geriatric concept is being discussed. Somebody at 65, the complication rates are 19%. Somebody at 80, the complication rate is 30%. So we should be able to use this data, number one, to make an alert within the team. Number two, to make the family aware that this is the universal data, that 30% of such people die not because of the bleed, not because of the endoscopy, because of their comorbid conditions. So once you take such a consent, which is also documented in the textbook, you are not only mentally prepared the family, offloaded your stress, but you are safe in the court of law that look, all this which is international literature was conveyed to the family. Now angiography can be DSA controlled, and the rebleed in angioectasia and AVM is high. When we inject or embolize through DSA, there is a risk of ulceration, necrosis, perforation. Perforation can be free peritoneal, or can be localized seal perforation. I have known in a couple of years ago when I was rotating in foregut surgery in Cleveland Clinic, there was an elderly lady. She was embolized for duodenal bleed. So after embolization, they tried to do localized embolization, but the GDA was important vessel in that patient. No, GDA got thrombosed and the collaterals were poor at that age. So the patient had a massive duodenal gangrene, and the ladies come to that. So what I'm trying to say, in best institution, in most experienced interventional radiologist, the complications of embolization are there. So my young surgeons, when asked about embolization, in one breath should be able to say this can lead to necrosis, number one, ulceration, number two, and perforation, A, generalized, B, localized. Contrast nephropathy again is to be taken care of in patients with angiography, and the common modifiable risk factors are diabetes mellitus, congestive failure, and dehydration. Now, while we are going to do embolization, it is a good practice to inject some vasopressin through the vessel, because that will lead to vasospasm. The two walls will come near and then you embolize it. But there is a risk in elderly age group that it can precipitate acute MI or arrhythmia in an elderly patient. So having done that, now when everything fails, the last choice is surgery. Now rarely, because the surgery carries very high mortality in this age group, and the surgery, if required, is usually because of either the duodenal ulcer bleeds, where the ulcer has eroded posteriorly, and the second surgery is a massive bleed from colon requiring a subtotal colectomy. The mortality in both situations is 30% plus. So friends, as a summary, the GI bleed, upper or lower, carries high morbidity and mortality. There is potential risk of coagulopathy in these patients. There is a potential component of polypharmacy, and the three drugs, namely anticoagulants, warfarin or novel, antiplatelet, and NSAIDs, precipitate the bleeding. And we have to understand the coagulation cascade very well. This evening I will request all youngsters to read up the coagulation cascade, the intrinsic and extrinsic mechanism of blood clotting. I would love that somebody will post on this, below this discussion, the intrinsic and extrinsic pathways, and that will be highly appreciated. And it's a teamwork. is a teamwork of ER people, the ICU group, the acute care surgeons, and gastroenterologists, radiology, and pathology. From my side, when I finish this, I will post the protocol-based approach for upper GI and lower GI bleed as recommended recently. Sorry for starting the lecture late. I was stuck in traffic because the snow outside today has been tremendous, and see, the whole Cleveland is white today. There's around 2 feet of snow all around us, but then still my son pushed me out of snow and we hurried somehow to reach to start this. Thank you very much for being with us late evening, and we appreciate your inputs. Please surely add on your ideas, your concepts, and if there are some queries, I have a lot of bright faculty with us who would answer on my behalf if I cannot answer. Okay, thank you. Bye.